Thank you very much for your patience. We are now going to begin our webinar today where Newtopia and Aetna will be taking you through our groundbreaking results of our 12-month randomized control trial that were recently published in the Journal of Occupational and Environmental Medicine. I really appreciate you taking the time today to join the webinar. And my name is Jeff Ruby. I am the founder and CEO of Newtopia. And what I'd like to do to begin the webinar today is just take a moment to introduce Newtopia and provide some context about the exciting work we're doing around disease prevention in the workplace. Newtopia is a personalized health company, or otherwise known as a precision health company, that's focused on disease prevention. And we've created a novel, hyper-personalized disease prevention platform that's really targeted at individuals or employees at risk of clinical obesity, type 2 diabetes, heart disease, and stroke. And we partner with large insurance companies like Aetna or other self-insured employers to deploy disease prevention programs specifically targeted at that at-risk employee base who can be identified either through biometric testing or through the response to a screening questionnaire, and have really been able to deliver industry-leading outcomes with regard to engagement, clinical improvements, and now some proven in-year cost savings. To get to understand Newtopia a little bit better, really at the heart of what we do is a belief that the answer to sustainable behavior change lies within each individual, but you have to take the time to really get to know people, to crack the code, so to speak, and take that understanding to shape an experience that's meaningful for them. It's really the difference between doing wellness or health prevention to someone, or rather the way we look at it, which is wanting to help prevent disease with the participant. And the way that hyper-personalized engagement platform works really focuses and centers on Sally. She's the star of our show. She is the at-risk individual who's been identified by her employer, who we are now focused entirely on getting to understand her to shape this experience. And at Newtopia, that starts with this unique combination of wanting to understand Sally both from a genetic perspective and also from a behavioral perspective. On the genetic side, I would say Newtopia is a novel genetic engagement company. We're looking at a very narrow band of genes that have been well studied and connected to weight and lifestyle issues to really help Sally understand what it is she's inherited from her parents that may be having an impact on her weight and lifestyle. And the goal here is for Sally to understand the biology at play so she can stop blaming herself and understand that there may be some genetic forces at play. We also want to arm Sally with a degree of control over what to do next by leveraging that genetic information to shape the recommendations we make in nutrition and exercise and behavior management. So ultimately, we're delivering Sally genetically driven recommendations that go beyond the guidelines. That's something that's built from her and for her. And the net impact is really this big aha moment, generally this spark to drive behavior change that's highly effective. We combine that with some very sophisticated personality and behavioral profiling, whereby we want to understand Sally's personality type, her motivation type, and her readiness to change. And as we combine the genetic understanding with the behavioral understanding, we're able to create this very powerful engagement experience. And so first off, what that enables us to do is figure out who should deliver that content to Sally. And the way that Newtopia delivers that is through personality-matched coaching to an individual, a group of individuals that we call our inspirators. In Sally's case, she'll be personality-matched to Sophia, who will be best suited to work with Sally to inspire, motivate, and engage her to change her behavior over time. And they'll meet live online through a video Skype, video chat conversation over such HIPAA-compliant platforms as Skype, FaceTime, or Google Hangouts. That information also provides us with the information we need to prescribe the right content to Sally from a nutrition perspective, and exercise perspective, and behavior management perspective. But not only prescribe it, actually figure out how best to deliver it to Sally. And the tools that we have for that will be a personalized app or a web interface designed specifically for Sally that over time will dynamically change and evolve as Sally evolves in the program. We provide her with a wireless and cellular scale that works right out of the box to make tracking of her progress fun and easy. And we also integrate with any wearable activity tracker, either that we deploy to Sally or that Sally has herself and connects to our platform. And then finally, the information that we collect about Sally helps us to present a gamified experience. So understanding Sally's motivation type, we're able to both host and encourage her to participate in the kind of games that would be most appropriate for her to motivate her. And then lastly, we want to introduce Sally to a group of 15 to 20 other people, either within her employee base or our broader community, that are just like her, that share a similar genetic background, similar age, and similar risk factors. So there's a group of individuals who understand her, are going through the same experiences, and can support one another on their journey. And ultimately, this entire engagement experience has one goal: to achieve a 7% body weight reduction for Sally at the end of the year. And then into the next year, we want to elevate those results to ensure that they're not only sustainable, but that Sally can achieve her own personal goals. We're so confident in our ability to pull these pieces together to engage and drive outcomes that we actually go at risk for our fees to ensure that Sally is engaged and achieving those outcomes. A tremendous evidence of this work has been the trial that we've been involved in with Aetna Innovations over the last several years. And I'm delighted today to be joined by Dr. Gregory Steinberg, who will walk you through the specifics of that work. By way of introduction, Dr. Steinberg serves as the head of clinical innovation at Aetna. He was previously the CEO and president of Active Health Management between 2010 and 2011, and their chief medical officer between 2000 and 2010. Prior to Active Health, Greg was the Associate Director of Medicine at St. Luke's Roosevelt Hospital City Center in New York City from 1992 to 2000, and an Associate Clinical Professor of Medicine at the Columbia University College of Physicians and Surgeons. He's currently an emeritus attending physician at St. Luke's Roosevelt Hospital Center. Dr. Steinberg received his medical degree from the Welsh National School of Medicine in 1978, trained in internal medicine and cardiovascular disease at St. Luke's Roosevelt in New York City, and is board certified in internal medicine and cardiovascular diseases. Greg, thank you very much for joining us today. I'll now turn over the presentation to you.
Thank you, Jeff. So if we could maybe just shift straight through to the next slide, slide 6. So this is just a brief overview of the Innovation Labs and what we do and how we do it. We've been in existence for roughly about 4 years, and essentially we function as a clinical research and development arm of the enterprise as a whole. We are looking mainly at areas of medicine that are on the bottom of the slide where there's a lot of volume and or a lot of cost, but not exclusively. And we try to identify issues that are on the bleeding edge, as it were, of what is the art of the possible. And then through a combination of either data analytics and or clinical pilots, an example of which we'll get to in a second, we will test out a concept with the predefined success metrics, and to the extent that we prove out that something does in fact work, the goal is to then commercialize it more widely throughout the enterprise. And we go through a fairly rigorous stage gating process, which is detailed on the right-hand side of the slide, so that we essentially focus the majority of our efforts on those initiatives that have the greatest chance of success. So that's an overview, kind of what we do. If you could go to the next slide, please. So to preface and contextualize what we've done most recently around metabolic syndrome, we actually did some preliminary pure data analytic work with one of Aetna's large customers who had, in addition to the normal amount of data related to medical claims, diagnoses, procedures, drugs, and lab data, also had multiple years of full metabolic syndrome testing done on their employees. So all of those data points were available, and we worked with an outside data analytic, so-called big data analytic company called GNS Healthcare out of Massachusetts to try to construct a predictive model that would, as accurately as possible, predict an individual and or a population's risk of developing metabolic syndrome 12 months down the road. And that work was published in the American Journal of Managed Care and is what is listed on this slide. As a part of that analytic process and project, we also looked at which specific factors of the 5 metabolic syndrome risk factors was the most important in terms of predicting subsequent metabolic syndrome risk overall and or costs. And perhaps not surprisingly, but nonetheless it was pretty emphatically determined in the study, the largest, most important factor was waist circumference. So armed with this data, we decided to embark on a project that looked at people who either had or were at risk for metabolic syndrome and see if we could impact the issue of weight management. So that's the background, if you will, to what we're going to talk about for the rest of the time. If you could go to the next slide. So just to briefly recap metabolic syndrome, which is probably familiar to most of you, essentially it's a constellation of quite a number of fairly common abnormalities, which are listed on the left of the slide. So waist circumference, triglycerides, so-called good cholesterol or HDL cholesterol, blood pressure, and blood sugar. And essentially, if you have 3 or more of those 5 abnormalities that are out of range, you are considered as having metabolic syndrome. The reason it's an issue is that, first of all, it's highly prevalent. Up to a quarter of the entire U.S. adult population has metabolic syndrome. But and not only is it prevalent, it also is associated significantly with risk of developing downstream serious problems, including diabetes, heart disease, stroke, and death, and has an increased cost associated with it, which, according to our own data, is at least 1.6 times more than an average person that does not have metabolic syndrome. If you could go to the next slide. So, and Jeff went through some of this. We're going to get to some more details in a minute, but essentially the overview of the program involves personality match coaches, which are called inspirators, and care specialists who achieve these high levels of engagement and sustained behavioral change. Jeff mentioned that we have there are a number of ways for people to communicate, whether it's Skype, phone, email, between their coach and their care specialist and the patient, and access to online portals and mobile applications. So the genetic profile we're going to get to in the next slide, that information is combined with a proprietary psychosocial assessment to create a truly personalized plan of action for that particular member or patient. In terms of the mechanics, program employees received a starter kit in the mail, which contained a genetic screening kit and an activity tracker. This was all done on a voluntary, purely voluntary opt-in basis. Go to the next slide, please. So in terms of the genetic testing, so again, on a voluntary opt-in basis, folks provide a saliva sample. The saliva sample gets tested for the 3 genes that are listed on the page, FTO, MC4R, DRD2. And although it is clear that there are many more than just 3 genes that are associated with obesity, these 3 particular genes have been written about extensively and clearly play a significant role in the overall profile of obesity. FTO, again, mainly linked to the development of obesity itself. MC4R seems to be related to appetite and food intake issues, and DRD2 because it's related to the dopamine receptor, has to do with cravings and rewards. Essentially, what the results of these 3 gene tests provide is a directional profile that can then be utilized by the coaches in a way to more accurately personalize the treatment plan for the individual patient or member. To be absolutely clear, the study was not designed to test the actual validity of the genetic component of the program. It is an inherent part of the program, but it is not possible from the results of the study to determine what is the actual part of the genetic component of the program that caused the results. Go to the next slide, please. So here is a waterfall slide, and this is taken from the paper itself. Essentially, we recruited people between June and September of 2013. The intervention was for a year between July 13 and June of 2014. And it takes you through, I'm not going to read all the numbers, but essentially we included individuals who were adults who had at least 2 out of the 5 metabolic syndrome risk factors that were out of range, one of which had to be waist circumference. There were certain exclusionary criteria that were applied that are listed in the second box. And then we randomized 2,800 and change people into 3 groups. Essentially, there was a control group, and then there were 2 intervention groups. One of those intervention groups received the risk prediction, and that was that basically the results of the predictive model that I talked about that we had developed with GNS Healthcare. And the other intervention group of 945 was not assigned to receive risk prediction. Because we were constrained due to budgetary reasons, we cut the program off arbitrarily after the first 600 folks had registered, and that led to a net of 445 people being actually enrolled. Of those 445 people, 421 actually provided pre and post program weights, which is obviously relevant, which we'll get to later. So that is the waterfall of the people that were invited to the program and how we got there. Go to the next slide, please. So here are the baseline characteristics of the 3 groups, group 1, group 2, and the control. And essentially the bottom line is that relative to demographics and high-level comorbidities, all of the groups were essentially similar at baseline in terms of their characteristics. Let's go to the next slide, please. So here's the enrollment and engagement rate results. So again, group 1 did not have metabolic syndrome risk prediction. Group 2 did. And the a priori hypothesis was that providing individuals with information about their 1-year future rate of developing metabolic syndrome would positively affect their enrollment and or engagement. And in fact, we did not see that. If anything, what we saw is that, at least with respect to enrollment particularly, the group that did not receive prediction seemed to enroll at a somewhat higher rate than the group that did. In terms of engagement following enrollment, they were both about the same. But we were not able to demonstrate any benefit of providing prediction information to these individuals. Go to the next slide. So here are the clinical outcomes, and the most important is the top bullet, which talks to the results of weight. So again, the majority of the folks that of the 445 did report pre and post program weights, and of those, about 3/4 of them lost weight with an average weight loss of 10 pounds, which was a 4.3% of their pre-program weight, which was highly statistically significant. What you see in the table below that is two sets of data. One is for the entire invited group, and the other below that is for the people that actually participated. And then what we're looking at is what were the effects relative to the 5 metabolic syndrome risk factors. Clearly, for the invited group as a whole, other than perhaps triglycerides, there was no statistically significant effect. For people who were program participants, and we'll get to commenting on this a little bit more later, but for the actual participants in the program, there was a statistically significant effect seen relative to waist, triglycerides, and HDL. We were not, in this particular study, able to see any statistically significant effect on either blood pressure or blood sugar. If you could go to the next slide, please. So this actually lists the results relative to cost outcomes. So again, the table is laid out just similarly to what it was in the prior slide. You have the invited group on the top half of the table. You have participants on the bottom half of the table. And you're looking at total medical costs. You're looking at inpatient costs, outpatient costs, emergency room, and pharmacy. In terms of, again, the overall invited group, there is no statistical significant change, but for participants, for program participants, there was highly significant change of about $122 of total costs savings per participant per month. And this is important to point out, given that program fees were on a per participant basis only, this enabled the program to achieve a positive return in its first year, which is highly unusual for lifestyle programs. If you go to the next, thank you. In terms of limitations to the study, this was done on Aetna employees, so clearly a single employer, and that has its implications in terms of limitations. As I mentioned before, because of resource constraints, the registration was artificially limited to the first 600 individuals. The weight loss data was self-reported, and at the time that was the only way we got that data. We did exclude individuals who participated in other Aetna programs of lifestyle management, but we did not or didn't know necessarily if individuals were participating in non-Aetna sponsored external lifestyle programs like Weight Watchers, etc. We did not look at productivity specifically in the study, and I think that's something that probably bears looking at in the future. And clearly looking at participant group results raises the issue of selection bias. On the other hand, given the participation rate of 14% and the fact of the per participant program charge that I mentioned before, we believe that does at least provide some rationale for focusing on the participant results. Go to the next slide, please. So what we conclude is that that this particular program showed that a clinically targeted, and it's important to emphasize that this was a targeted program. These were not average, quote, individuals. These were people that had, at least as I said, 2 out of 5 metabolic syndrome risk factors that were out of range. Just another parenthesis statement is that their baseline costs of about, in the control group, if you went back a couple of slides, was about $434 per member per month. That's significantly higher than the average baseline costs for a person that is, quote, healthy. So these were individuals that already had medical issues to start out with, but for a targeted group, that this kind of highly personalized wellness program can in fact result in improvement in engagement and clinical outcomes and cost within just 1 year. And that if this kind of a program was deployed and implemented at scale, it would be expected to produce significant benefit downstream on the major risk factors and significant medical events such as hypertension, diabetes, heart attack, stroke, heart failure, etc. If you go to the next slide. So one of the criticisms is, even for people who accept the results as they are at face value, is that, well, look, this is fine, but this is only this is results for 1 year, and you know, in the second year, what happens then? Do people just put their weight back on, and so on? So what we did is we actually looked at that, and for those individuals that had lost some weight in year 1, we actually allowed them to continue at with a much lower touch program in year 2 to see what would happen in terms of both their engagement levels and their weight loss. And we have 2 slides. This one that you're looking at now is for individuals, looking at individuals who had lost at least 7% of their baseline body weight in year 1. And by the way, that's a significant number relative to deriving significant metabolic benefit. So these are individuals who'd lost at least 7% of their body weight in year 1, and we're following them over time in terms of their weight loss as reported in the time frames on the x-axis. The green bars represent the amount of weight loss, and then the blue line is their engagement rate. And the bottom line is that there continues to be significant and sustained weight loss in year 2 for these folks, and continued significant engagement. If you go to the next slide, we also looked at people who had lost weight, but somewhat less than the first slide that I just showed. So these are folks that lost between 3 and 6.9% of their initial body weight in year 1, and same idea, it's presented the same way. And although the results are perhaps a little less striking, they still show that there is significant and sustained weight loss and reasonably sustained engagement in year 2 for these folks with a lower touch program. So that we're continuing to look at that, by the way, and we will hope to report final results, including utilization and cost relative to this year 2 once those become available. We don't have that as of yet. So that brings us to I think the end of the prepared remarks, and ready to take any questions.
Just before we take some questions, Greg, I really want to thank you very much, and also thank your entire team at Aetna Innovations and the broader Aetna team who have really worked hard over the past now over 2 years in partnership with us We really appreciate your confidence in us and your really bringing some credibility and verification to our novel approach to disease prevention. I also really want to thank my incredibly dedicated team here at Newtopia. You cannot find a more world-class and hardworking group who are working day in and day out to really, truly change the health of the world. And to them, I thank them because these results are really a testament to their efforts. And with that, we would like to very much take some questions and answers. And so to the extent that there are questions for the balance of the hour, we are happy to answer them. And if you just insert your questions in, we're not going to unmute the mics because that could get out of control. There are hundreds of attendees on the call, but you can ask questions through the GoToWebinar panel. And I'm just queuing them up now. I see a number have come in, and I'll read them aloud and then provide an opportunity for either Greg or I to answer. Great. So first question is, I'm confused about how genetic testing plays a role in the overall program. Do you diagnose heart disease and/or diabetes using genetic testing? Thank you for that question. I can answer that. The answer is no. Newtopia is not a genetic diagnostic company, nor are we attempting to use the genetic information we collect to identify risk factors for metabolic syndrome. As I mentioned earlier, the risk factors for metabolic syndrome can be identified either through a biometric test or through the answer to a screening questionnaire. When we start working with participants, it's post-identification of risk, and the genetic testing there is very much as an engagement tool. So it's not necessarily to corroborate or to support any risk finding for metabolic syndrome. Rather, it is strictly there to identify these genetic factors that may be at play for weight and lifestyle, and help to inspire and provide a sense of control by tailoring the prescription that we make around nutrition recommendations, exercise recommendations, and behavior management recommendations. Second question, what happens to the participant's DNA, and do you share the results with the employer? Not surprising to have some questions about the genetic testing side of what we do, and I too can answer that. The one thing that is really important to remark is that we take participant privacy and the security of their DNA results extremely seriously. And so all genetic testing happens through a physician prescription. So we are not a direct-to-consumer genetic testing company, but every participant in the program will have a physician-prescribed genetic test that will be sent to them in an alphanumeric bar-coded number, so it's completely de-identified and anonymized. And then those results, that testing kit will be processed by the individual. It's a simple spit kit that one can do at home. We provide instruction and how to actually take the test, and then that test will be sent back in a pre-addressed FedEx envelope to a CAP CLIA lab that processes the results for us. Once those results are processed, usually in roughly 2 to 3 weeks' time, the results are then provided to Newtopia and Newtopia only, and only at that time do we connect the personal information from the alphanumeric code to the individual so that we can share those results only with the participants in the program. It's important to note that at no time do we ever share genetic result information with either a participant's employer or insurer, and we are fastidious to adhere to the strict GINA guidelines that are in place. Thank you for the question. The third question, weight loss of over 10 pounds over the course of a year doesn't sound very significant. Greg, maybe I'll let you take that answer. And given your experience in programs of this kind, maybe you can speak to the 10 pounds relative to the percentage of body weight reduction.
Yeah, thanks. Based purely on statistical analysis and using, p-values, it was in fact statistically significant. Also based on what happened to those individuals who lost weight in terms of their other metabolic syndrome risk factors. In other words, what happened to them clinically, there seems to be statistical benefit. And last but not least, in terms of their cost, there seems to be benefit. So there is a plausibility chain, if you will, that that amount of weight loss did in fact lead to significant clinical benefit. In the literature, you somewhere in the range of 4 or 5%, you start to see benefit. This was about 4%. So it's also internally consistent with what the rest of the literature does say in terms of being able to see, start to see benefit in terms of what happens to individuals.
Thank you. We have another question. What would the recommendations be outside of the guidelines based on genetic testing? I can take that answer. So really none of the recommendations ever fall outside of the guidelines. And so the core of Newtopia is an integrated expert team made up of registered dietitians, clinical psychologists, pharmacologists, exercise physiologists, physicians, and geneticists. And together, they have ensured that all of Newtopia's recommendations fall within existing evidence and guidelines, including the CDC's diabetes prevention program for those at risk for diabetes, as well as guidelines and recommendations for heart disease prevention and stroke. At no point are we moving outside of guideline recommendations with the genetic testing results. In fact, what we're really doing is using the genetic results to help narrow down within the guidelines and to be more precise so that we can really identify what would be most effective for each individual. To provide an example, of the 3 genes that we offer, each are tied to evidence and recommendations we make around nutrition and exercise and behavior management. So one variation that we may see can help us to narrow in within guidelines the right proportion of macronutrients, fats to carbohydrates to proteins, for that individual to be most effective to achieve their 7% body weight reduction goal. Another gene has indications around the form and intensity of exercise that would be most effective for each individual. So that variation would help us to narrow in whether or not the time spent actively should be spent more geared toward getting a heart rate up as opposed to just in moderate activity. And then a third gene that we look at provides indications around behavioral support and whether or not an individual will have the likelihood of greater cravings or the inability to receive satiety signals around certain types of food, which can help to shape the kind of behavioral support, again, within existing guidelines that we would provide. So, really, to reiterate, the idea behind the genetic testing is not to move outside of the guidelines, but rather to hone in and be more precise so that the individual feels that now these recommendations are not only guideline compliant, but they're being built from them and for them to be successful. Another question that's come up is the genetic component a required piece of the program, and would biometrics be sufficient? Here, the answer is no, it is not required. The genetic testing piece is 100% voluntary, as is participation in Newtopia, as Greg mentioned earlier. We found, in fact, that it's been a highly sought-after feature, and of the approximately 4,000 participants that we have had the honor of working with at Newtopia, I can count on one hand the number that opted not to participate in the genetic testing component, although it is an entirely voluntary piece, and those who do not want to participate can still absolutely participate in Newtopia's personalized platform. Another question, Any concern of the length of study and bias of the study group because they were Aetna employees? Greg, again, I know you spoke to this before, but perhaps you want to speak a little bit more toward that limitation.
Well, yeah, we mentioned it as a limitation that it's a single. I'm not sure that they were Aetna employees as such is the issue, but it's it represents a single employer experience. I think that is a legitimate potential criticism, and it is what it is. We are in the process of deploying it more widely to other customers, and time will tell whether these results are reproducible. We believe they will be, but time will tell. In terms of the duration, the 1 year duration was somewhat arbitrary because that's kind of how we tend to run our pilots on a sort of calendar year cycle. But as I also mentioned, we are continuing to look beyond the 1 year period to see, to look at the sustainability of the effect in both from the perspective of clinical outcomes, engagement, and cost.
Thank you. We have another question. Can you speak to how engagement is measured? Are these engagement measures consistent with other digital interventions for weight loss and diabetes? This is one that I can answer. So together with the team at Aetna Innovations, we came up with a very strict measurement of engagement on a monthly basis to deem whether or not a participant was in fact engaged with the program in that month. And so the engagement method that we've used is whether or not, so a participant would be deemed to be engaged if they are tracking nutrition on 12 of 28 days, or activity on 12 of 28 days, or behavior on 12 of 28 days, or if they participate in a coaching session in the month, or if they participate in a Newtopia community-based event or activity challenge in that month. If any of those things were to occur, or in most cases we saw multiple engagement on a monthly basis, then that participant would be deemed to be engaged for the purposes of our analysis and also for the purposes of billing. I can't necessarily speak to whether or not that's consistent, but we certainly felt that that was an adequate measurement of engagement. Thank you for that question. These are wonderful questions. Sorry, I'm just queuing through the list now. Do you plan to look in the future at how the difference in genes affect outcomes? That's a great question. One of the things that we are very focused on here at Newtopia, as certainly is Aetna, is the analytics and data side. And so we are certainly spending an awful lot of time evaluating and trying to understand the model implications of which genetic variations and factors may have an impact on both engagement and outcomes. And it is our hope that we can continue to do the great work that we are doing alongside Aetna and publish more and more data with regards to the role of specific genes and their impact on engagement and long-term outcomes. We also have our own genetic research and development group here at Newtopia that are not only looking at the narrow band of genes that we worked on for this particular study, of which Dr. Steinberg mentioned the FTO gene, DRD2, and MC4R, but are considering the addition of other scientifically validated genes that could help us to improve the predictive quality and the hyper-personalized quality of our program, and also will be the subject of our evaluation and publication into the future. Here's another question on genetic testing. Genetic testing is very controversial. Are companies interested in opening up this can of worms for their employees? Greg, why don't you take a first crack at that? I think I have maybe a more biased opinion on what I've seen thus far to date, but from your perspective, what are your thoughts?
Well, the short answer is it appears to be, in the sense that, you know, when we've discussed this type of program with our customer base, many of them have shown great interest, particularly, to be fair, as we keep saying, none of the genetic results go back to either the employer or the insurer. And once that is made crystal clear to all concerned, that, you know, any anxiety related to that issue dissipates. There are a lot of employers that seem to be interested in fundamentally trying to find solutions that work for what is arguably a very thorny problem. The other side of it, interestingly, and this is purely anecdotal, but it is what it is, and was provided spontaneously by at least some of the employees who participated, that they actually enjoyed getting this information. Not only did they enjoy getting this genetic information back, but in many instances they felt that it allowed them to gain greater mastery over their weight problem, demystified it to some extent, and took some element of guilt out of it. And this was unsolicited anecdotes that we received from some of the people who participated in the program. But the short answer is we appear to have significant interest at multiple levels for deploying a program that appears to, quote, work.
I would, the only thing I would add is that our experience to date has, in both the trial work through Aetna Innovations and through our broader book of business, is that the genetic testing component is highly sought after by employees, and in fact, each one of the programs we've deployed and implemented to date have been oversubscribed, and clearly some of the engagement rates that we've seen to date in the 30 to 35% are considerably higher than what the industry generally sees, and we think a lot of that can be attributed to that bespoke, personalized, and hyper-personalized approach. And lastly, it appears that through the right kind of communication around privacy, the interest around something personalized to each individual seems to trump the concern over whether or not we can manage to maintain the confidentiality appropriately. It's not to say that it's not critically important, it certainly is, but I'd say the participants that we've engaged with, this sense of wanting something built for me as opposed to something that is one size fits all, which ends up being one size fits none, tends to really trump and be of greater interest. We have time for 2 more questions, and there's one here that talks about does Newtopia utilize a PMPM charge, and what is it? What is it for the program? And so I thank you for that question. The answer is a no. I mentioned earlier that Newtopia has a real interest in aligning with our employer partners, and our goal is very much only to, we don't have any setup or administrative consulting fees, and we really charge on a voluntary basis and only for engaged participants per month. So it's a per engaged participant per month charge, and that means that we are really held accountable to achieving engagement rates and outcomes. And as Greg identified, we've been able to now prove a $1,464 savings, which is the $122 per participant per month times 12, which created an in-year return on investment, which also is unprecedented for a disease prevention program of this kind. Final question, and this one actually is specifically asked to Dr. Steinberg. Dr. Steinberg, why did you choose to work with Newtopia for this study?
Yeah, look, we evaluated a number of potential partners to go with. We wanted to do something around metabolic syndrome. We have, as I think I made obvious, a sort of limited budget for our various initiatives, and at the end of the day, we have to pick one. We had a fairly structured process for evaluating the partners that we're going to work with, and for this particular purpose and for this particular pilot, Newtopia came out ahead of the other vendors that we evaluated, and we felt that their approach was unique enough that we felt we wanted to look at it as objectively as possible to see if it worked. As I said, they were one of a number of contenders, and we went with them after the end of a fairly rigorous selection process.
Great. Well, thank you very much, Greg, for, again, your presentation today. Thank you very much for everyone who was able to attend. Unfortunately, we're just approaching the top of the hour, and there are a number of questions that are still coming through, and we'd like to answer them all. We will be, we've recorded this webinar and we'll be making it available on our website, along with a blog posting that will have the answers to all of these questions, including the ones that we have been unable to answer. So if we weren't able to answer your question, apologies in the time restraints, but we will endeavor to answer each of them and post them to our blog. And to the extent that anyone is interested in learning more about Newtopia, we encourage you to visit newtopia.com, and would be delighted to schedule a free consultation to really help understand how we can help to improve your workforce's health and deploy some industry-leading disease prevention programs. Thank you, and have a wonderful rest of the afternoon.